We move on to the next speaker, which is Professor Nobuhiro Fukunari, Vice Director of the Showa University at Yokohama Northern Hospital. And he will tell us what are the pathological changes after radiofrequency ablation, how unhappy is the surgeon after this procedure.
Thank you, Chairperson. I'm Dr. Fukunari. I'm an endocrine surgeon. I'm flying from Yokohama, Japan. At first, I really appreciate the kind invitation of Dr. Barakabi. My presentation titled Surgical and Pathological Changes after Sinus RFA. This introduction, radiofrequency ablation has been reported as useful and non-surgical treatment for locally symptomatic sinus nodule. In this series, 6 benign sinus nodules treated by RFA previously undertaken surgical resection for different reasons. As you well known about the surgical specimen after RFA can give us many kinds of information. First of all, evaluation of the efficacy of RFA, and second is comparison of ablated area between the US images on RFA and actual pathological images. And third, we can check the presence of tissue adhesion, which will cause a problem during the surgical procedure. In 2004, ethanol ablation for secondary HPT was approved as national healthcare insurance coverage in Japan. So that the number of ethanol ablation for secondary HPT has been increasing until 2007, when the approval of Cinacalcet. So that during 2001 to 2007, later, many patients with SHPT had been received ethanol ablation as an alternative to PTX. Ethanol ablation for SHPT showed unsatisfactory results. Critical complications, example, laryngioneuropathy, and also cause complication of severe tissue adhesion, which leads the surgeons complaint and rejection against ethanol ablation for SHPT. At the same time, with the clinical trial for the evaluation of ethanol, case 1 is 64 years female with thyroid papillary cancer. She accepted the cooperation of this study. Ethanol ablation was carried out 1 day before surgery. 1.0 milliliter ethanol was injected, aiming at reducing the intranodal blood flow. We do the Doppler-guided injection. Sinus surgery was done next day after ethanol ablation. You can see the CAT section and the HG images. Resected specimen and the HG images show the necrotic changes in the center of the tumor, which was similar to ethanol perfusion area. This is another case, the case 2. Sinus surgery after several sessions of therapeutic ethanol ablation. 35 years female with 5 centimeter hyperplastic nodule, 5 or 6 times therapeutic ethanol ablation had been performed, but satisfactory result was not obtained. HE shows the ethanol ablated area shows a necrotic and the fibrous changes, but it's a partially. And also severe tissue adhesion around the side of the capsule after the several sessions of ethanol ablation. In this presentation, we have 453 RFA for sinus nodule. Consists of 386 hyperplastic nodules, including 49 hyperfunction nodule, and 6 postoperative Graves' disease recurrence, and 28 primary micro-PTC, and 33 postoperative lymph node metastasis and local recurrences. This number is gathering 2007 to 2018. We have now over 500 cases at present. In this series, 5 female and 1 male, total 6 patients had their thyroid operation after RFA, age between 34 to 51. The period from RFA to operation ranged between 19 to 52 months. Surgery, in all cases, the reason they need surgical removal was due to the growth of another nodule besides the post-ablated area. Hemothyroidectomy was done in 4 cases, and total thyroidectomy was done in 2 cases. This table shows the patient's age and tumor size and the period from RFA. And this table shows the operation and the operation time and postoperative pathology. I'm going to show you a typical case, case 1. This is a 37-year female hyperplastic nodule. RFA was done for the right thyroid nodule. Here you can see this is pre-RFA images. And 6 months later, ablated the area down to the dark side. And in 33 months after, another new nodule are going up. The diagnosis before RFA was benign hyperplastic nodule. In the follow-up duration, another nodule increased besides ablated area. Hypervascular new nodule could not be denial of follicular cancer, so we decided the thyroid surgery for her. Right hemothyroidectomy or a central neck dissection. Pathology is a follicular adenoma. Here you can see the ablated area is a necrotic tissue, and new nodule is benign thyroid follicle. And you can see the fibrodegeneration around the necrotic tissues. There are no adhesion and degeneration changes of the thyroid tissue surrounding the post-ablated area. This is another case, case 2, 48-year female, hyperplastic goiter. She has a large thyroid goiter and hopes to reduce in size for a cosmetic reason instead of surgery. And also, her concern was lifelong LT4 replacement after surgery. So we do the RFA, has showed partially successful results, which would not be satisfied her desire. You can see the right lobe and the left lobe. After RFA, the size will partially decrease, but it not satisfied her desire. So that enhanced CT shows the unclear boundary between the ablated area and the sternothyroid muscle on the right. But on the left, clear boundary line was preserved here. So we did total thyroidectomy. The operating time is 105 minutes. It's too much longer than the usual. So in the operation, adhesion and degenerative changes was shown at the right side of the capsule and isthmus. You can see the fibroid degeneration of thyroid membrane. Unclear boundary area might be affected by the thermal damage. The area adhered to sternothyroid muscle. These changes required careful attention in surgery. Discussion. Pathological changes in post-ablated area was coincident with the estimation of intraoperative US images on thyroid RFA. The restricted control of ablation inside the nodule have not affected thyroid tissue surrounding to the post-ablated area. And safe thyroid surgeries have been performed without any complication. But we must pay attention about the thermal damage expanding to out of the nodule could cause the tissue adhesion between the thyroid capsule and surroundings, which could bring surgery to a much complicated situation. And also we are usually moving short and trans-ischemic approach is a standard way of thyroid RFA. With trans-ischemic approach of RFA, estimates might be affected by the thermal damage. Histological changes in estimates show the hard degeneration of the tissues. Here, so we must pay attention about for the isthmus, not only the tip of the electrode. Discussion: thermal damage expanding into outside the nodule might cause adhesion between the thyroid capsule and surroundings. With trans-isthmic approach, isthmus might be affected by thermal damage through the route of electrode insertion, which depend on the size of active tip. Severe adhesion will require the combined rejection with laryngeal nerve, vessel, or surrounding on surgery. This is my thought. The difference between the eternal ablation and RFA. Can ultrasound estimate actual ablated area? Eternal ablation sometimes difficult. RFA, possibly, yes. Is there any leakage from the puncture site? Eternal ablation, often. Eternal leakage outside nodule mainly due to the tissue stiffness. Of course, it's injection volume, injection speed. It may be depend on the leakage, but I think it's mainly due to the tissue stiffness. And also, additional eternal ablation will make the tissue much more harder, much more adhesion, and complication might be shown. RFA, no leakage, but expanding ablation outside the nodule might cause a tissue adhesion. Conclusion: pathological examination of surgical specimens showed that thyroid RFA could not affect to the surroundings and restricted control of ablation. Intraoperative estimation of ablated area inside the RFA should be considered sufficiently for a safe and satisfied treatment. In other words, well-controlled RFA procedure could not cause a problem on thyroid surgery, so that it's not similar to eternal ablation for secondary HPT in Japan. This is conclusion 2 from surgeon. Thermal damage to superficial tissue, such as skin, platysma, sternocleidomastoid muscle, maybe wider skin incision will be required, but which will not be a serious problem. On the other hand, the thermal damage to the posterior tissue, laryngeal nerve, esophagus, trachea, combined rejection of the nerve, esophagus, will cause a severe complication, and the patient quality of life must be declining. Thank you for your attention.
Thank you, Professor Fukunari. The lecture is open to the questions.
Paolo Limone, Torino. I didn't understand the last slide. Have you observed a case in which there was a damage to trachea, esophagus, and laryngeal nerve? No. No.
Identify yourself, please.
Well, good evening. I'm a surgeon from Prato, Italy. Thank you for your presentation. I have an experience, even if thermoablation and in surgery after thermoablation, and I do confirm your results that thermoablation is not a problem for a subsequent surgery. I have an experience of about 100 radiofrequency and 2 cases of intervention for various with some indications. And I can confirm what you said just a few minutes ago. I would like to make a question to you. I don't know if someone in your institution has laser and thermoablation. Because I see different results. I don't have experience of laser, but it seems to me that the volume reduction of laser is inferior to the volume reduction of thermoablations, looking to literature and of what I saw in your presentation. I would like to ask if you prefer laser or thermoablation, and if there is an indication, if there are different indications for the 2 procedures. Obviously, in groups that have both laser and radiofrequency.
Okay, is there somebody that can answer the question, even if he's not a speaker? Okay, you will talk tonight with somebody and he will answer your question. Okay, thank you, Professor Fukunari, thank you very much. I think we are going to finish this first day of the meeting.